Question. If you've been told by a healthcare professional that the leg pain, the back pain, the difficulty walking that you may be having, or the ability to stand for very long, or the fact that when you go grocery shopping or in a store you have to lean on a cart because after a while it becomes difficult to stand. If you have any of those things and a healthcare professional has told you it's due to arthritis or blames it on your age, or perhaps your only option is to take medication, and if that doesn't work, we can try some therapy, and if that doesn't work, you may end up needing surgery. If that's something that rings true to anybody here, just raise your hand for a second, if you would. Everybody look around the room for a sec. It's common. And I have good news for you. Tonight, I'm here to talk about it's a very natural approach to this condition. It gives you the ability to regain the ability to walk, to function. Very often you're able to either eliminate or reduce the need for any medication. It's able to prevent surgery. And most importantly that we see with our patients, it allows people to start regaining parts of their life back, the ability to walk, stand, go to functions, and go to activities. And it does so with an 85% success rate. Now, in healthcare, most of us would like to believe that 85% is common. I got to tell you, that's not even close to being common. 30% would be a very good response to a lot of things in healthcare. So an 85% success rate is actually very good. So we're going to be talking about this in about the next 30 minutes, and I hope this can be fun for everybody. I hope you are allowed to ask questions. I want to make sure everybody's here, so if everybody would just raise your right hand for a second, I want to make sure they're working. Is everything working here? Now your left arm too, both of them? Okay, all right, we got arms at work, everybody here is good. That's excellent. And please feel free to ask questions as we go through tonight. I'm normally not locked into this microphone. I move around, but with the distance and also with the mic, I'm kind of stuck here. So please forgive me. I'd like to tell you a little bit about why I'm so passionate about this subject. In fact, I'd like to tell you why I've gone back and got additional educations and certifications in this program, because it's quite personal to me. And this actually goes back and has to do with a family that I know very well almost 40 years ago. It's a family of patients of mine from 40 years ago. Okay. Now, we've got to stop here for a second. Not one of you looks surprised that I've been in practice almost 40 years. So can I have at least one face that looks surprised? Oh, much better. Now I feel much better. Thank you very much. But it goes back to a family, and it was a family, a mother and father, that had 7 children. And the mother and all 7 of the children have been patients over the years, and they had been at this time. And they've all really enjoyed tremendous benefits from chiropractic and done very, very well with it. The father never did. And I don't question things. The family would come in, the children would come in, and he would bring them in oftentimes. Sometimes he would come into the treatment room and sit there and watch, or he would drive them and I could see him sitting in the car. And it was fine because for whatever reason, I didn't know why, but he didn't choose to partake of our services. And this started, he was probably in his 50s when this started. By the time, and by the way, his name was George also, just happens to be a coincidence. And by the time he was in his 60s, I started noticing that he was having some difficulty moving. He wasn't as agile. And it was one of those things that when I'd watch him get up out of a chair, he wouldn't straighten up. He would kind of bend in his, I call it the gorilla walk, where the butt goes back and you kind of have a hard time straightening up a little bit. But then it would kind of loosen up. And being a chiropractor, it's hard for me to not recognize that kind of stuff. And I would say to him at some point, "Are you okay?" And he would go, "I'm fine. I'm fine. No, everything's good." And I would just let it go. But when you've worked with somebody and their family for a long time, you start to know them a little better and you start noticing these things. And as time went on, by the time he was in his 60s, he was really struggling with moving and walking. And it would be to where you could watch on his face the expression of the discomfort when he would go to get up and walk. And as it went on a little further, I would notice that when he got out of the car, he wouldn't actually walk into the office. He would walk about 20 steps, and then he would stop on the railing and kind of do something like this to lean over, and then he'd stand up and come in. And I try to let people come to me rather than push myself on them. But at one point I finally said, George, you really seem to be struggling. Are you okay? And he says, I'm fine. I'm fine. He says, all I need to do is, I get a little soreness every once in a while, but all I got to do is stop and sit down, or I just lean forward and it goes away. Well, I had a pretty good idea what that entailed or what that involved. And I said, well, if you ever want me to take a look at you, we do a lot of work with this, I'd be glad to help. And he would always say, no, I'm just fine. By the time he was in his 70s, I started getting reports from the family that he was starting to give things up. But it was never because he was in pain or having problems. It was, I'm not going to cut the grass anymore. I'm going to get a kid to do that because, it's just so hot out anymore and I don't like it. And then he was real involved with the American Legion. He was an officer and had been for years. And he said, well, I don't think I'm going to run for office anymore. In fact, I'm not going to go to the meetings anymore. And the family would tell me, he's saying it's because he doesn't enjoy the people that have turned over in the Legion anymore, but the real reason is he has to walk 2 blocks from the parking lot and go up 2 flights of stairs to get into the Legion Hall, and he has trouble doing that, and he's embarrassed, so he doesn't want to do anything. And over the time, I had offered quite a number of times to do this. In fact, I started at one point wondering, does he just not like me? I mean, I'm a likable guy. Do you not like me? And the family says, no, it really has nothing to do with you. He just doesn't do this well with doctors' things. He ignores kind of all his doctors, the ones he even sees. And this had progressed to where it was just so obvious he was in pain just trying to walk into the building with his wife. And one day he sits down and he says to me, hey, what's your opinion? I'm having some problems with my back, and I'm thinking of having surgery. What do you think about that? Well, the family had kind of prepped me a little bit ahead of time to tell me that he had been doing this. And so I knew this question was coming. And I also knew from the family that he had a relationship with his family doctor. He didn't do what he said, but he at least listened to him. And I said, well, did you talk to your family doctor? And he said, yeah, I did. And I said, well, what did he say? He said, well, he didn't think it was a good idea for me. And I said, well, he's exactly right. And if you have what I think you do, here's why it's not. It has very poor success rates. It does not work for this condition. And I explained everything to him. Now, I also knew that this was a guy that was a little bit on the stubborn side. And I thought, you know what? Rather than hearing it from me, I said to him, George, I'll tell you what, if you would like, one of my friends is the head of neurosurgery at one of the major hospitals here in Pittsburgh. In fact, he is world-renowned for developing most of the spinal surgeries that are done all around the world. If you would like, I will call him and get you an appointment to see him, and you can go talk to him, and I would trust whatever he says to you. And he agreed. So he went to the appointment, came back, and I said, how did it go? And he said, yeah, he said the same thing you said. And the same thing my other doctor said. I'm just not a good candidate to come out of this better. And I said, okay. And I thought that subject was done. I said, I'm still here if you would like me to take a look at you. No, I'm okay right now. Fine. Unbeknownst to me, he had already been doctor shopping. And unbeknownst to me, he had already found someone who had made him all kind of promises about surgery, about how well he was going to do. In fact, he told my mother, his wife, and George that you will be a new man when we're done with him. You're going to be a new man again. And he had surgery. Now, prior to the surgery, he was able to walk maybe about 50 feet before he would have to stop and lean on something. He was on oral NSAID medications, Motrin, Naproxen, all the time, all day long, every day. Didn't really help him. This medication doesn't help him, but he said he was afraid that if he didn't take it, it would get worse. Was able to care for himself, get dressed, go to the bathroom, shower, and basically had a very limited life, but was able to do most body functions. Had the surgery, and boy, was that surgeon right. He was a new man afterwards. Afterwards, for the rest of his life, he never walked without a walker again. That 50 feet that he was able to do beforehand became a struggle just to get from his living room to the bathroom, to go to the bathroom, and pretty quickly he lost the ability to control that, and one thing led to another. He started to spend more and more time just sitting and laying and doing it. In fact, he spent basically the last 8 years of his life sitting in a chair, in his recliner, or laying in bed sleeping, very little movement around, and spent the last 2 years in a nursing home. And during the time, that last 8 years, he developed diabetes, congestive heart failure, the dementia, as well as Parkinson's, all of them. And it was just awful watching someone waste away. And you know, the things that are really tragic about this is several things. First of all, watching someone when you know there's something that you can do to help or perhaps prevent some of this decline is very difficult to do. But you know, this thing that doesn't get talked about necessarily a lot is what I got to see this happen to his family, to watch his wife and his children go through all this and watch them decline, and they basically had no control to help him and do that. And you know, you may have figured this out by now, but the reason I know this so well, this was my father-in-law, okay? So this was very personable. I saw what this meant to my wife. I saw what this meant to my mother-in-law and the impact it had on the family. And that's why I decided to do something about this, to go back when I had the opportunity and I learned about this new program, to go out and get certified and to learn how to do this, because there really has been nothing out there to really help these patients well and to change their life. So to understand a little bit about what we're going to be talking about tonight, let's talk about what is lumbar spinal stenosis. Now, technically, the stenosis means a narrowing or a closing down. And I have to tell you that when I went to school years ago, but actually we believed this until probably about the last 5 to 10 years. In fact, most physicians still are under the impression that the claudication, or that narrowing that we see, does that work? There we go. That narrowing that we see in the spinal cord. This is the spinal cord coming down through here. And if we look on the normal side, you'll see it's wide open and there's no constriction whatsoever. If you look at the side with stenosis, it's wide open until we get down here, and it almost looks like something has choked or narrowed that off. And we all believed that at one point that was bone and disc material and other tissues that were physically squeezing the cord and putting pressure on the nerve, because it kind of makes sense. The only thing that didn't make sense is why these patients can sit down and almost get immediate relief. That didn't make any sense, because if it's a hard bone or hard tissue pushing on a nerve, how does sitting down change that? It's just too narrow. And that's one of the things that confuse it. And researchers, probably starting about 10 years ago, really came to understand what this really is. Lumbar spinal stenosis does have some bone, does have some things, but that's not the problem. It's actually a vascular problem. It's like a varicose vein. Anybody familiar with a varicose vein? You know how they blow up and they get enlarged and they kind of get engorged? That's what happens. There's a venous plexus, or a group of blood vessels inside the spinal canal. And in these areas that are narrowed, that plexus becomes engorged and squeezes the nerves. And that's actually what causes the pain, all the paralysis, and all the other things that happen with this. This is also why when you sit down and that blood leaves that area, kind of like the person with a varicose vein that puts their leg up in the air and all of it drains out and the vein kind of goes away, same thing happens when you sit down. All that blood drains out of the vein and the pressure goes away and you get relief. But it's just temporary. So that's what spinal stenosis is all about. Now, what are the main symptoms? We talked about some of them already. Things like lower back pain, buttock pain, and pain into the legs, and very often it's in both sides. Now, you can have any combination of those things. We have patients that have nothing but foot pain. We have patients that have back, butt, leg, and foot pain, or any combination of those things. It doesn't always have to be both sides, it just commonly does. This is most common after over age 60, but I have to tell you, we're actually seeing patients in the early of age 30 that are exhibiting signs of this, but it certainly is more common after age 60. The pain gets worse typically when you stand or walk. That's why they walk for a little bit, they stop, they have to lean on something, lean over and bend, or they have to sit down and they get relief. And that's one of the things with stenosis patients always say, I'm fine, all I gotta do is sit down for a few minutes and I'm okay. And it's true, the pain goes away that quickly. But as soon as they stand, it starts building back up again and comes back here. The symptoms get better with bending forward and also sitting. And generally these patients will sit. That was my father-in-law. He spent years sitting in a chair because it's the only place that he found comfortable. Now, we were talking a little bit before about how common these things are becoming here. We really don't realize how common this is becoming, and there's a reason for it. For example, this is actually causes more life limitations than congestive heart failure and COPD, chronic obstructive pulmonary disease. That's what we used to call emphysema, okay? It causes more life limitations than that. It causes more difficulty for people to walk than hip and knee arthritis, which we all know how common those are. This comprises the most common spinal surgery over age 65. And that number there is a little low now because this is a few years old. It's well over $2 billion are spent just on the surgical treatment of this alone. It's a leading cause of disability and loss of independence in the elderly. The studies that were done on this in Japan, that's why it's listed up here, as of 2012, this comprised about 9% of the Japanese population, and it's not different for us either, by the way. It just hasn't been studied as well here as it has been there. And the Canadian government has estimated, because again, they've done a study, that in 10 years from now, both the United States, Canada, and most of the civilized world, it's going to comprise about 25% of the people in the population here. It also, for people over 65, it's almost half of the, it's the reason that about half of the people who go in with lower back pain, with complaints of lower back, leg pain, and things like that, it's the cause of why they would go to see their primary care doctor. This increases with age. The disability and the risks associated with as we get older tends to increase. And you know, there was a time when you used to see a lot of people, but you don't see a lot of people in walkers and wheelchairs as much anymore, specifically with this condition. And there's a reason for it. They really have a hard time leaving their home. These are people that just getting from their living room to their car sometimes becomes a major life effort and is very uncomfortable for them. So they tend to be very solitary and stay at home. With this, you also become a very high fall risk, and as we all know, hip fractures are one of the leading causes of death in older population, but also with disability. And the reason for this is not only the pain that you have, but associated with that pain, you start losing balance, you start losing agility, and as you get weaker and weaker, the condition makes you more likely to not be able to ambulate and step over something that you may not see. So the risk falls increase tremendously. We've all heard about comorbidities with COVID, haven't we? You know, and we all hear about, you know, if you have this and this, you're more likely to problem it. Well, there's a number of things that we know are associated directly with this. Things like diabetes, congestive heart failure, chronic obstructive pulmonary disease, as well as Alzheimer's and dementia. And by the way, just so you understand why this is, those are entirely related to a sedentary lifestyle. As the person's ability to function and move in their environment decreases, all of these things increase drastically. And so the stenosis can be a leading cause for those things. So why does this happen? Well, the sad part about it is the main cause of this is the aging process. Does anybody know, did anybody ever wonder why little older men, their belts tend to end up around here? And we're all going to end up that way, guys, so don't feel bad about it, okay? Does anybody know why that happens? It's not just a dressing thing. Why would that happen? Why would our belts tend to move up to here?
Does the spinal bone shrink?
The bones don't, but the discs do as part of the aging process. So by the time we hit in our 80s, that's why we start, everybody knows as we get older, we may lose some height, right? Well, where you lose the height is in your spine. You don't lose it in your legs, okay? So as the spine gets shorter, your torso gets shorter, and that's why the pants seem to be moving up. And so that is part of this process. It is aging, and that is a big part of it. Another part of this is heredity. Now, these two things we don't have a lot of control over. And by the way, this explains why this is increasing in the population, because you have to realize that 40, 50, 60 years ago, when the life expectancy averaged about 65 years, people weren't living long enough to have this be a problem. Now that the life expectancy is going into the 80s and well beyond, I mean, we know we're going to be seeing many, many people living into the over age of 100. This is becoming more and more of an issue. The first two things there, the aging and heredity, are things that we obviously can't control. I mean, you can't go back and pick your grandparents and get new ones. You are who you are, and we're all going to be aging as time goes on. Probably the most devastating part of this condition that we do have some control over is trying to prevent the progressive loss of function and mobility. And just because this is something that all of us have the potential to deal with, and a large percentage of us will end up with, it doesn't mean that there's not something to be done about it. It's the decline in that physical mobility that causes this to be a progressive condition. And let's just stop there for a second so that we're all on the same page. What I'm here to tell you tonight is there is no cure. There is nothing that you can do once you start with spinal stenosis to not have it any longer. And that's whether it's surgery or anything else. Those problems continue even afterwards. There are things that you can do, though, to maintain and to manage that program. I want you to think of this condition almost like diabetes. Once someone's diagnosed with diabetes, they're always going to be a diabetic. It's not going to go away. But it is something that if you manage it properly, you can avoid a lot of the complications, you can live a normal life, and you can take active steps to do something about it. And that's what spinal stenosis is, and that's what the program we're here to talk about tonight. It's how do you manage this condition? To understand that, let's talk about the common treatments for this condition that are being used now. And they basically are going to fall into four categories. Number one is prescription medication. Number two is injections, usually spinal type, epidurals being the main one. We call it manual therapy, but that would include chiropractic, osteopathy, physical therapy, and any other physical medicine type problem that way, or treatment that way. And the last would be surgery. All of these things are commonly used for it today, and unfortunately none of them have been shown alone to be able to actually stop the progression of this disease and to potentially reverse some of it to get some of that function back, perhaps a lot of it back. That's what's unique about the program here. So we'll start with the oral medications. Prostaglandins, gamapentins, these are drugs that are used for other problems that have been pushed into the stenosis market, as well as all of the NSAID family, Motrin, Naproxen, Feldene, there's a whole host in the Celebrex. You can go on and on with all of these. And this also, by the way, would include the narcotic drugs too, like the opioids. The research that's been done with this, and by the way, before we go on and talk about any more research, I want to just tell you who I am about research, because this is really important. We could conduct a research study here, like I said, who here thinks I'm a really great guy? And, oh really? No one raised their hand? Oh, thank you, thank you. Well, we could just do that, and we could say, well, you know what? 2 out of 10 people thought that I'm a really great guy. And that's a study. Does it mean it's valid? No, I could be a serial killer on the outside. It doesn't mean that it's valid. And in healthcare, as well as in all science, when people talk about different types of research, there are different levels of scrutiny that research goes under. Everything I'm telling you tonight comes from journals and from research that has undergone the highest level of scrutiny available, period. Nothing here is my opinion. This is based on things that get published in the Journal of the American Medical Association. Spine. They have to go through years of scrutiny to get put into these magazines to be published, and these studies have been verified a number of times. So when it comes to oral medications, what we know is the research has shown that these clearly do not improve the pain scores, the ability to walk, even in the short run. What's interesting about that, I don't think I've ever had a stenosis patient who isn't taking these all the time. And it was for the same reason that my father-in-law did. At one point, they may have gotten a little relief from it, and they say, I'm afraid if I don't take it, it'll get worse, so I want to continue to take it. We all know the troubles that we're having with opioids. Even they don't work with this. The oral medications, as well as the opioids, lead to another complication. And this isn't a made-up word, by the way. This is something we're seeing more of, polypharmacy. And what this means is that we're all familiar that drugs have a side effect and can have one, right? We understand that because the manufacturers will do research and say, okay, you're likely to have this, you could have this, this, and this from a medication. And that's just part of the process. What we don't have a good feel on is when we start combining so many medications and how they interact with each other. That's where we really start losing sight of what the potential here. And we know it's a problem. When people are taking 15, 22 different medications, all for very different reasons, how those chemicals all start to interact when they intermingle with each other creates another set of problems that we don't even understand at this point, but we know it's a true problem. Epidural injections. These have been around for a long time. These would include spinal epidural injections, but they would also include injections in the soft tissue and trigger point and other things that way. The evidence is very clear on this. They don't work. They're not effective at reducing pain levels and or improving the quality of ability to function and walk. And that makes a lot of sense because particularly epidural injections are mainly to reduce swelling. They have a pain-relieving portion which is very short-lived, but they also have drugs in them to help to reduce swelling. This is not a condition that is caused by swelling. It's caused by that varicose vein kind of thing squeezing the nerves, and that's why they don't work. Surgeries and physical therapy combined. And this would also include chiropractic. Each one of these things individually can well, let me say this. Chiropractic and physical therapy have been shown to give small, short bursts of relief, but they don't stop the progression of the condition by themselves. And surgery has been very clearly shown that when they look at patients who go through these complicated surgeries, the success rate is less than 20%, to be honest with you. But to give you an example why I say that's not even, I don't know that I believe that. Do you know my father-in-law was considered a surgical success? And the reason for it is it reduced some of his leg pain. The fact that he couldn't dress himself, couldn't shower, couldn't bathe, couldn't walk or do any of those things wasn't taken into consideration because their only goal in that surgery was to try to reduce some of the leg pain. They did, but it didn't make a difference. The back pain remained just the same. So 2 years after going through a very complicated recovery from surgery as well as therapy, the vast majority of these patients showed no difference in their ability to walk and the pain levels that they had. And again, these were published. So there's a really bright guy. He's actually from Toronto, Canada. His name's Dr. Carlo Amendolia. And he's the one that developed this program. And he's a very unique individual in that he's both a clinician where he treats patients and he's also a world-renowned researcher. And usually those two things don't work together very well. You're usually kind of one or the other. And being a clinician and treating people, is a chiropractor, he started noticing that, you know, these patients with this spinal stenosis, yeah, they get some relief, but we're really not able to get them back to where they're able to do more and to function better and to get off some of the medications or get off of it altogether. And it was very frustrating. So he started looking at the research and he realized, well, the surgeries don't work, the drugs don't work, whatever. But in the course of his research, he started noticing that some of these therapies, particularly some of the chiropractic things and some of the physical therapy things, did provide little bits of short-term benefit. And I believe that what he thought was, you know, I wonder what would happen if I started taking these little pieces that do seem to give some benefit but just isn't long-lasting, and we start putting them together into an organized program and see if they'll work synergistically to create a better outcome. So he did. And he put a research program together, and they did it. And he started treating these patients, and they started following. Because his first goal was, Number one, he wanted these patients to be able to walk better, walk further with less pain, and he wanted them to be able to maintain that as they age. Everything that's the opposite of what happens with stenosis. With stenosis, if left unchecked, it gets worse. You have more problems walking, more pain, more disability. He wanted to see, can something be done to change that? And so his first goal is, we're going to do this, and then we're going to look back at these same people 1 year later. And what he found is, 85% of the people that followed the program and did it 1 year after they went through the treatment program had still had a significant improvement in their ability to walk, their ability to function, the distance they could walk, and their pain levels, and all of those things had statistically improved. And he says, I think we got something here. The study that he did was published in the Journal of the American Medical Association, and it was actually repeated. The study was repeated here in Pittsburgh, believe it or not, at UPMC, and that one got published in Spine, I think it was 2 years ago, by the researchers here at the University of Pittsburgh. So this is something that has gone through pretty significant scrutiny. So what's different about this program? And what did he want to do with this to make this so that it could be reproducible? Well, he wanted certain things to be true. The first thing he wanted it to be is he wanted it to be standardized. And this was really important because if you say, hey, I got some ideas and we should do this, and you give that to a bunch of doctors, if you do that, 6 months later, everybody will be doing something different. They all want to put their little thing on this. And he says, no, this has to be a standard, something that is standardized, so when someone does it, they can expect that same 85% success rate. It was very important to him. It has to be comprehensive because in all of his research, he found that no one profession had all the answers. It wasn't just a chiropractic thing, and it wasn't just a physical therapy thing. It was actually emotional things had to be dealt with. And the patient had to become involved in the treatment plan, kind of like how they do it with diabetes now. You know, in the old days, if you were diagnosed with diabetes, they would say, well, just take this and go home and talk to you later. Now they want the patients to understand their blood sugars and what they need to do with iron and how they need to take care of themselves. And they want them emotionally involved with this. And he realized the importance of that. And the last component that was really important to him, because he is a researcher, is this has to be evidence-based. And that's a term that you're hearing more and more about healthcare. You know, we have a lot of procedures that we can do for people. Like, for example, I could give everybody here a glass of water, and we could all drink it, and I could say, does anybody feel better after drinking that glass of water? And some of us would say, yeah, you know what, I do. And we could say, well, that proves that that water helps us to feel better. It doesn't really stand the validity of being evidence-based. Evidence-based means that we're going to do studies, we're going to follow through, we're going to have specific criteria to be actually able to measure if that made someone better, how can we do it? And his criteria for this was an improvement in ability to walk and an improvement in the pain scores and the disability scores. In other words, people could walk better, move better, had less pain, and it was documentable that they could do this. So he wanted it to be reproducible as well as evidence-based. And in his approach here, he broke it into 3 different parts here. So there was the self-management portion of this, and this is so important. I made the analogy to diabetes before. Like I said, diabetes used to be the healthcare person did everything for you and told you everything, and you took no responsibility. Now we know that's not the right way to treat this. We need the patient involved, and it's the same thing here. Our patients get very involved with their own care, and they need to understand what the condition is so that they can avoid the things that are aggravating, so that they can do more of the things that are beneficial and can take an active role in their health care rather than just sitting in a chair. Exercise is an important part of this, and let me say it's a really big part of this, okay? Really big. In fact, to be enrolled in the program, you have to qualify for this, and one of the things is you have to agree that you're going to do the exercises. This isn't something that the doctor says, I need you to do this twice a day, and in the back of your mind you think, maybe I'll get to it when I'm not too busy. If that's the case, it's not going to work out for you, and I'm telling you that now. What I am telling you, though, is if you do these things, you have a very good likelihood of actually improving and doing better. But exercise is an essential component of it. And one of the questions that I always get is, well, how long do I have to exercise? Anybody thinking that right now? How long do I have to do this for? Well, my answer is as long as you plan on breathing. Because exercise and activity is a part of life, and for this condition, it's something that has to be done not just during the treatment phase and not just afterwards. You know, that's one of the things as a healthcare provider that I just find so unfortunate. I'll have a patient who will undergo a knee replacement or a hip replacement, and they'll go through and do therapy, and I'll watch them getting better, and then the moment the therapy's done, they're done with that too, and then I watch them going like this, back down again. Exercise is an important component, but for this, it is essential. So it is not negotiable, folks. It is part of the treatment here. The last part of his triad here is the manual therapy, and this is the things that the doctor is doing to you. And this is done during a short window. He calls it his boot camp programs. And this is done over, depending on the condition, it can be as short as a 6-week program and get results there. So the results of this boot camp program that he found that 85% of the patients who had mild to moderate disability, what that means is these are people kind of like my father-in-law. If it's a severe disability where they're bedbound and they can't exercise, can't help them. But if they're able to move and get along like that, 85% of those patients will show an improvement in pain levels and in their disability scores and improvements in their ability to walk in 6 weeks. And I got to tell you, it actually comes for most of the patients in the first week to 2. They actually start seeing those changes very quickly. Now, when he first did the research, he wanted to make sure that this could be maintained. So the original research showed that he did, that it was good and lasted up to 12 months. This part here where it says about the long-term study, that's actually up to 5 years right now because this is a relatively new program. So they've been following the people that have continued this, and 5 years after the program was done and they continue to work on it at home, and with some of the help from Dr. Amendola, they're still maintaining, their pain levels have improved, they're still able to walk better, and they're still able to do that. You know what's really interesting about that? The average age of the people in these studies was mid-80s. So this isn't a young population of people at that level. This is a population of people that that's very surprising about. So it is a very, very effective program here. I want to share some actual case studies with you here. This is a lovely, lovely lady. I love her. She was probably one of the most skeptical people I've ever known, and it had nothing to do with the treatment itself. It had to do that there were other health complications that she thought might be the reason for this, and she really felt as though nothing could be done for her because of these other health complications. In fact, the stenosis she looked at that she knew she had, and she thought it was a minor problem, she kind of didn't believe that that's why she couldn't walk and do the other things. This was an extremely active woman. She was an active golfer. She hiked. She traveled. She did all of this stuff. And for the 2 years before we started with her, all that stuff had gone aside. She didn't golf anymore. She couldn't hike. She could walk a maximum of about 5 to 10 minutes max on a good day, and then she would have to stop and rest and let the pain subside. And basically felt as though because of some of the other health issues that that's the best she could do. And she looked into this and came in. She set me a goal, and it was funny because when I sat down with her, I said, what would you like to do? What's important to you? And she says, I want to be able to walk 25 minutes without stopping. And I said, that's all? And she said, that's enough. And when I said, well, I like our patients to have big goals, she says, I don't want big goals. I want to be able to do 25 minutes. I'll tell you, she did that on her 4th treatment. She was able to do that after her 4th treatment. She's golfing this whole summer. She's been able to take hikes around Peterswood Park, the lake out there, and walk for 45 to 50 minutes at a time. And it's not to say that for every patient, all of their problems go away. It doesn't necessarily work that, because a lot of it depends on how far they've advanced into this decline. The deeper people are, they're still going to get benefits from it, and they still have the 85%. But the idea is we want to try to prevent more things before it gets to that point. She's done very well. This was a fellow that one of my patients who doesn't even have spinal stenosis is his neighbor. And she said, my neighbor, who's in his 70s, walks like this. And has for about 4 years, can't straighten up. And I see him out and he's in his yard trying to get around, but he can't straighten up. And he's been that way for a long time. We started working with John after his second treatment. He stood up and then he looked at us and said, I can't believe I'm standing like this. He does well. He works in his yard. He's walking. He's exercising. Remember before I said about how the exercises are real important? Well, we had everything going really well, and then he decided that he was going to cruise for a little bit. He's going to give himself, a month's vacation from the exercises. And he didn't fall apart entirely. Actually, he just declined a little bit. But he started noticing all of a sudden he started stooping over again. And all we had to do is just get him back on the program, make him do the things he needs to do. And he's been great and doing very, very well. This is Connie. Connie thought her problem was knee arthritis. She came in because she does have some arthritis in her knees, and she thought that the reason she couldn't walk very far was because her arthritis in the knees were a problem. But she also had little back problems. Wasn't too bad, but it had gotten to the point where she really wasn't walking very far, and she was starting to do those things where she was asking other people to go to the store for her and all this stuff like that. And someone told her to come in. And when we looked at her, she said, I think it's my knee. And after we looked at everything, she said, no, actually it's coming from your back and you have this condition. She's off all medication, walks as far as she wants, she does everything. The wear and tear in her knee she still has, but the pain wasn't coming from that. It was actually coming from the stenosis. And she's been doing very well for well over a year. This is an interesting fella. He actually smiles a lot. You wouldn't know it necessarily from this picture, but he's a great guy. He came to us because he couldn't walk even 100 steps. In fact, he rarely left his house. He had such pain in his legs, and his was a case where he had no back pain. It was all down in his calves and his legs. But he would get such pain that he would have to it would just stop, and he would just have to sit to get relief from it. And this had been going on for about 4 or 5 years. We started working with him. When we started, he couldn't even walk 100 yards, which we figure is somewhere less than 200 steps for him. That's one of the things we measure. By the way, we do the same thing that Dr. Amendolia does, and that is we measure. We want to know, how many steps did you do today? How long did you work out in the exercises? Did you do all your exercises? This isn't haphazard. There's a system to it that makes it work. After his 6-week program, he was doing over 2,000 steps without having to stop. And his pain level's gone, and he started getting out again. And I just saw Jack last week, and I said, how's things going? How are your steps going? He says, I'm still doing 2,000 steps. Not necessarily every day, but he can do it, whereas before he could never get past 200. 95. So this happens and this works regardless of age, regardless of the condition, as long as the patient is able to cooperate and work with us here. Who here would like to have some results like that, if you could? Yeah. Well, obviously when it comes to healthcare decisions, you have the power to decide what it is. Oh, by the way, does that look like it would be difficult to do right here?
It's pretty flexible.
Do you know that most of the patients that go through this will be able to actually take their knees and touch their nose? And so I don't know how many of them will do it standing at a bus stop, but at least they'll be able to do that as part of their exercises and the things that they do. But in any case, as I said, obviously you have the power to decide what you want to do in healthcare and make decisions that way. I want you to consider for a second, though, because this is a progressive condition. This isn't something that goes away. If you are having some of these difficulties, and let's say that in 6 months or a year the condition gets worse and becomes hopefully not to the point where it's gone too far and can't be helped like my father-in-law, but let's say it's just gotten worse. You know, I know my wife and my mother-in-law regret every day that my father-in-law refused to take care of himself and to get help when the help was available to him. Now, wouldn't it be awesome, on the other hand, if you are having some of these limitations that perhaps in as short as a month or so, perhaps as short as 6 weeks, or for like most of our patients, even as short as a couple weeks, that you're able to see that your abilities to improve and function better would happen in that short a time. And that's not unusual. That's why we developed at our office, we call it our Regain My Health consultation. Now, let me tell you what this is not. This isn't one of these appointments where you go to see a doctor and maybe a doctor or somebody else comes in and talks to you for a little bit after you've waited an hour to see them. And very often I've had the experience where they don't even look at you, they just type into a computer, and when it's all done you walk out with a prescription in your hand and you're really not clear as to what's going on or what's all happening. What this is where we sit down with our patients and do an in-depth consultation and a history, as well as taking x-rays if it's necessary. And why do we do this? Well, a number of reasons. Number one, first of all, we have to make sure that these patients qualify for the program. The reason Dr. Amendola is able to get 85% and we're able to reproduce this is we're not wasting time trying to apply a treatment for something other than what this is. And that's really important. The second part of this is because the average age of the people who have this condition is on the older side, very often they don't just have spinal stenosis. We talked about the one lady who had other health issues, or the people who have arthritic damaged joints in their knees and their hips, or other health problems that can complicate their recovery. And all of those things have to be factored into, is this someone that can actually recover? And if so, do we need to do anything in addition to make this all work together? So you have to understand the patient themselves and everything that they're dealing with, not just being a spinal stenosis patient. And then the last thing is, before we do anything with these patients, we sit down with them and their families and we explain what it is that we do, how often they need to do it, how often we're going to see them, what the costs are. We do everything up front so that there are no misunderstandings, because patients have to agree that they're going to take part in this. If someone doesn't want the exercise portion, God bless you, but it's not for us. We're not going to take part of it. You have to be able to take part in the whole process of this. Now, when we do all of that, our normal fee runs around $250. As part of the workshop tonight, what we're doing is we do it for $20. And why now? Why do we do that? Well, I'll tell you what. I learned a while back that I can't change my father-in-law's destiny and the things that he did, but I know that there's people out there that we can help, and most of them can get help, and we can prevent them from getting to that point with them. So we do that. And on part of that, we even offer a guarantee. And this is what it is. If you come to us, you do the consultation, you go through everything, and if we find that you're not a candidate for this condition, I'll just give you your money back. If I can't help you, I don't want it. In fact, we're not even keeping the money anyhow. We're donating it back to the library fund tonight anyhow. The other part of this is, if you go through and you've heard the whole consultation and you say, now that I've had a chance to think about it, this isn't for me for whatever reason, I don't want to do the exercises or whatever, you can have your money back. I want to find the people that I can help and want to participate in this. So if it's something that you'd like to do, Kim's going to be passing out some little forms. All I need you to do is just give us your name and contact information. She has some times on there that you can tell us what times kind of work best for you. And then before you leave tonight, you just need to talk with Kim. Unless anybody else has any other questions, I'm going to be hanging around here. If you have individual questions, you can come on up and ask me. But I wanted to thank you for coming out on a beautiful, lovely evening tonight. I want to share one last thing with you. There was a family had an interesting birthday tradition. And the birthday tradition, a lot of us will have a birthday cake, and when it comes to blowing out the candles, we'll make a wish and blow out the candles. This family had a tradition that for each year old you were, you got another wish. And they would have unlike most people where you keep it to yourself, they would have the birthday person read their list of wishes to the whole family. And it was kind of a fun thing because people could get to understand the kids and what was important to them in their life and the different things. And they could wish wishes for other family members and things too. So obviously each year it got along, the list started getting bigger and bigger. And this one particular year, it was the father of the family's birthday, and he was getting up there in age, and the family during dinner was saying to him, "Oh my gosh, we're going to be here all night listening to your list and whatever." And he laughed and said, "Yeah, I guess so." And it came time to bring out the cake and to him to go through his wish list, and he pulled out of his pocket a little piece of paper, a little Post-it, and on it he just had read, "The only wish I have is to get my health back." The reason I share that with you is that's something we all say. If you have your health, you have everything. And it is so true, but very often we don't always follow through with it. If you're having problems, I would love to speak with you. I'd love to be able to help you. Thanks for coming tonight. And if anybody has any questions, I'll be up here. And you can talk to Kim if you'd like something else. Thanks a lot.